Welcome back to the Global Summit. In this session, we're going to talk about vaccine efficacy, especially amidst ongoing viral threats to kidney patients, especially those who are immunosuppressed and immunocompromised. It's a special privilege to have Dr. Kevin Kavanagh, a doctor who started out as an eye, ear, and nose doctor with a career spanning 4 decades. He's widely known across the United States for his vigorous defense of the safety of patients in healthcare settings. He founded HealthWatch USA, which is an organization that has distributed fact-based materials, especially over the past 5 years of COVID, that patients and patient advocates find very interesting and oftentimes contain information that are not in the mainstream news or even in mainstream medical journals. He's candid, and his candor is appreciated, especially when folks like us are dealing with real threats that sometimes just don't break the news. But Dr. Kavanagh has been a strong ally, and we appreciate his interest in making certain that the right therapy at the right time is available to patients and that patients are encouraged to protect themselves. Amidst everything that's going on, we think that's wise counsel, not just here in the United States, but globally. Dr. Kavanagh, welcome back. Go right ahead with your presentation.
I'm Dr. Kevin Kavanagh, Board Chairman of HealthWatch USA, and I would like to talk to you about vaccine efficacy among ongoing viral threats in immunosuppressed and immunocompromised kidney patients. One of the major causes of death in kidney patients is infections. In dialysis patients, infections are the most common cause of death, overall accounting for 36% of all fatalities. In kidney transplant patients, infections are the second most common cause of death, accounting for a quarter of all deaths having a known cause. The most common cause is from cardiovascular or heart disease. Thus, infections are a major cause of death and disability in patients who are immunosuppressed from chronic diseases or who have undergone a solid organ transplant. One of the strategies which can be used to prevent infections are vaccines. Vaccinations have been very successfully used in the general population, but the question remains, how well will these work in patients who have chronic renal disease or who have undergone a kidney transplant? This is one of the questions this presentation will try to answer. In patients receiving dialysis, provided they are not immunosuppressed, vaccinations are viewed as both safe and effective. Here is a list from the National Forum of End-Stage Renal Networks of vaccinations which can be administered to patients receiving dialysis. Note that dialysis patients can receive both live attenuated virus and inactivated virus vaccines. Vaccines are encouraged in dialysis patients since they may prevent both morbidity and mortality. And in the last 10 years, there have been important changes, including the availability of the high-dose influenza vaccine and introduction of the hepatitis B, pneumococcal, COVID-19, and respiratory syncytial virus vaccines. In renal dialysis patients, recommendations for vaccinations tend to mirror those in the general population. Live viral vaccines such as measles, mumps, and rubella, or MMR, can also be given. According to the National Forum of End-Stage Renal Disease Networks, dialysis center protocols for the COVID-19 vaccine and respiratory syncytial virus vaccine remain uncertain. Unfortunately, most vaccines have not been extensively studied in patients receiving dialysis, and although consensus on the safety has been reached, data on efficacy is sparse. The same is true for kidney transplant patients. Extensive additional research needs to be performed on vaccines in patients who have kidney disease and renal transplants. There are more stringent recommendations for vaccinations in patients who have received a solid organ transplant. As shown in this slide, Stanford Healthcare recommends that for an optimal immune response, initial vaccination should be given before, not after transplantation. Most importantly, live attenuated vaccines such as MMR and varicella should not be given after transplantation. The shingles vaccine has not been well studied but is felt to be safe. Needless to say, this is another example of not having important data. Other vaccines, such as hepatitis A, B, and human papillomavirus, can be given pre or post-transplant, as can vaccines for pneumococcal and meningococcal bacteria. This table is from a 2023 review article by Vigano et al. I feel the authors did an excellent review and have information specific for the type of organ transplant and the data related to vaccinations. This reference, along with a number of other references which we talk about in this presentation and the slide set, is available for download from the homepage of healthwatchusa.org up in the right-hand corner. Now, although inactivated viral vaccines are viewed as being safe to administer post-solid organ transplant, they're probably going to be less effective. Monitoring of post-vaccination antibody titers is recommended for a number of vaccines, including hepatitis A, B, and pneumococcal vaccines. The authors also point out that the immunological response to vaccines in most patients with end-stage chronic diseases may be muted, and there are a number of concerns with immunization of patients with solid organ transplants. These include, number one, vaccination schedules rely on limited data, and clinical trials are not often designed specifically for organ transplant patients. Number two, the timing of vaccinations in relationship to immunosuppression regimes has not been well studied. Number three, live attenuated vaccines should be avoided. And finally, vaccine tolerance in end-stage chronic diseases is not well known. Now, I'd like now to talk about some specific infections. The first one is seasonal flu and the influenza vaccine. Efficacy of the flu vaccine in dialysis patients has been documented. This slide describes a 2018 study from Israel that found among dialysis patients who also had diabetes, 17% of unvaccinated patients contracted flu, compared to only 6.3% of those who were vaccinated. In this study, the vaccine efficacy in preventing infections in dialysis patients with diabetes was 63%. Among solid organ transplant patients, the data is less clear. There is a benefit from flu vaccinations in reducing all-cause pneumonia admissions by 17% and all-cause mortality by 40%. But there's no demonstrable effect in preventing influenza-related hospital or ICU admissions. And for me, a 17 or 40% reduction is far too low to not be doing active research in this area. Despite the potential benefits, flu vaccination rates in transplant patients were found to be low at 48%. Of concern is the recent call from our federal government for placebo-controlled studies for all new vaccines. These studies could delay the availability of COVID-19 boosters and delay the approval of other vaccines. If clinical trials are required for antigen-reformulated old vaccines, the vaccine's availability may well miss the targeted strain of the pathogen. This could happen with the flu and COVID-19 vaccines. The only aspect of the vaccine that changes are the antigens. The manufacturing process for these vaccines is unchanged. Now let's talk about measles. Unfortunately, the actual number of measles cases in the United States is not known. The CDC places the number at just over 1,000, but infectious disease Dr. Paul Offit places the number at approximately 3,000 cases. This includes 3 measles deaths, 2 of which were in healthy children. Thus, it is not just those with comorbidities who are at risk of dying, and the deaths were from, not with, measles. Measles is also the most contagious disease known to mankind. In areas having no community immunity or mitigation strategies, 1 case of measles would be expected to infect 12 to 18 other individuals. This compares to Ebola, where one case of Ebola would be expected to infect 1.5 to 2.5 individuals. With seasonal flu, one case would be expected to infect 1.3 individuals. In many areas of the United States, we have lost herd immunity to measles. It requires 92 to 95% of the population to be immune before herd immunity can take place. Immunosuppressed individuals should avoid traveling to regions having measles outbreaks, such as in rural western Texas. Measles is so infectious that if you walk into a room with a single patient in that room having measles, you're probably going to get infected. Dialysis patients can usually safely receive the measles vaccine, but this live attenuated virus vaccine is rarely given to those with solid organ transplants. Now, initially back in the 1960s, the measles vaccine was an inactivated viral vaccine, but it was abandoned due to its lack of acceptable efficacy and durability. And currently, the only vaccine available is a live virus vaccine, or MMR. However, there is ongoing research to administer the MMR and varicella vaccines to a subset of kidney and liver transplant patients. And there is evidence which suggests, and the key word here is suggests, that this can be done safely under certain conditions. Viago et al. Described some of the immunological parameters which need to be met and tested for before an attenuated MMR and varicella live virus vaccine can be considered to be given to kidney and liver transplant patients. The authors also warn that there are concerns regarding safety and there is a lack of efficacy data. In other words, there still may be substantial safety concerns with the MMR vaccine and renal transplant patients. And even if able to be conducted safely, we cannot be certain of the vaccine's effectiveness. Personally, I would only consider this option if I was able to obtain the vaccine at a large medical center and if I lived in rural western Texas. If an immunosuppressed patient is exposed to measles or likely to become exposed, passive immunity using intravenous immune globulin should be considered. Listed here in this table are some passive immunity protocols from the Washington State Department of Health. COVID-19. Unfortunately, there is a significantly lower vaccine response in immunocompromised patients to the COVID-19 vaccine, and this occurs even if additional boosters are given. This means, with the ongoing and continuing threat of COVID-19 infections, vaccination strategies alone will not provide the needed protection. Other steps should be taken to decrease one's chances of becoming infected. A number of other vaccines can be given to solid organ transplant patients, including the pneumococcal, tetanus, diphtheria or whooping cough, and pertussis vaccines. However, in kidney transplant patients, live attenuated vaccines such as yellow fever, salmonella, and cholera should not be given. These vaccines have been linked to vaccine-mediated diseases such as organ rejection, which is seen with the yellow fever vaccine. So far, there are a number of overriding concepts which we have discussed. One is that vaccines are more effective if given before rather than after transplantation. For some vaccines, post-vaccination antibody titers should be monitored. Vaccines still provide significant benefits in patients on dialysis with end-stage kidney disease, but vaccines may produce a lower immune response in these patients. Attenuated live virus vaccine should be used with extreme caution or avoided in transplantation in immunosuppressed patients. Ring vaccinations of family, co-workers, and pets are very important and help to protect vulnerable patients. Ring vaccination is a strategy that instead of vaccinating the individual, you vaccinate everyone around that person who he or she would be expected to come into contact with. I would like to now address some of the common areas of vaccine misinformation which have been circulating in our communities and in social media. First of all, all vaccines have undergone clinical trials. And new vaccines have undergone placebo-controlled clinical trials. This was even true for the polio vaccine, where 600,000 children were enrolled in a placebo-controlled clinical trial. Testing of all vaccines against a placebo is not ethical. If there is no alternate treatment, a placebo-controlled trial can be considered. But if there is an existing treatment, testing against existing treatment is what is needed. I would like to discuss two examples, the Ebola vaccine and measles vaccine. Ebola infections are highly fatal. In some outbreaks, the death rate approaches 90%. I agree with a large number of ethicists that having a no treatment control group would not be ethical. With the measles vaccine, if a new vaccine was developed, it should be compared to the existing vaccine so you can determine the new vaccine's true benefit. And giving a patient a placebo for a dangerous disease when a treatment already exists is unethical. Some older vaccines, such as flu and COVID, require updates for new strains. In this case, only the antigen in the vaccine is changed. If extensive testing is done, there will be a delay and antigenic drift in the circulating virus may take place, and this could make the vaccine ineffective. To summarize, testing of vaccines must follow ethical standards. Insisting on unethical studies, such as what was done in the Tuskegee syphilis study, does not make the vaccine safer. You need to maintain clinical equipoise so that each arm of the experiment has an equal chance of benefit. These are basic concepts in scientific research. And these illustrations are from a site called Unbiased Science. I would suggest using some of their illustrations and information when communicating to the public. They're just excellent. The second circulating narrative, which is misinformation, is regarding vaccines and autism. There is no association between vaccines and autism. This was demonstrated in a large Danish study from the Statens Serum Institute, which evaluated 6,517 children with autism. The rates of autism were not different between the vaccinated and unvaccinated groups. Another study published in the Journal of Child Psychology and Psychiatry studied autism rates in the city of Yokohama, Japan. MMR vaccination rates plummeted until there was not a single vaccination given in 1993. However, the rates of autism did not decrease. Instead, they increased, with a dramatic rise in the 1993 cohort. Again, autism and vaccines are not linked. Vaccines do not cause autism. And another false narrative is regarding vitamin A. Vitamin A does not prevent or treat measles. The benefit of treating measles with vitamin A has only been observed in malnourished children. We are already seeing in Texas children being hospitalized with measles and having to be treated for vitamin A toxicity and liver toxicity. So similar to vitamin D, iron, and oxygen, a small amount of the substance is necessary for life, but too much can cause toxicity and even be fatal. So to answer the question of how well do vaccinations work in kidney transplant patients, the answer is probably not as well as you would like them to. But we need to remember a suboptimal effect is still much better than no effect, and vaccines still need to be part of your armamentarium to keep from developing a severe infection. However, you have to also adopt other strategies, since added protections are needed. And some of these strategies are as follows. You want to check transmission rates, wear an N95 mask or respirator, carry a CO2 monitor, and to take special precautions during medical appointments. Now this graph is from Epic Research Communicable Diseases webpage. The link to the page is at the bottom of the slide and also in the material that you can download from healthwatchusa.org's homepage. One should check overall transmission rates in the United States along with rates in the state that you live in. Usually respiratory viral infection rates are low in May, and if you need to plan a high-risk activity, this is going to be a good time of the year to do it in. However, a lower risk does not mean an acceptable risk. You still need to take precautions. If you are going into a high-risk venue or participating in a high-risk activity, wear an N95 mask or respirator and take hand sanitizer and sanitizing wipes with you. Surgical masks and cloth masks will not provide you with the desired protection. A CO2 monitor will also help you gauge the risk of indoor environments. CO2 levels are predictive of air quality. I prefer levels below 700 parts per million, and CO2 levels above 900 to 1,000 parts per million, I try to rapidly leave the area. For medical appointments, special precautions are needed. Medical appointments are not only necessary, but take place in one of the highest risk settings you can be in. After all, sick and infected patients go to medical facilities. I would recommend that one do all of your paperwork online before you arrive. You want to schedule the first appointment in the morning so that there's less of a risk you'll be exposed to airborne pathogens. If you have to wait in the waiting room, you should ask the receptionist if you could wait in the car instead and be called back using your cell phone. You want to try to stay out of common areas as much as possible, and this includes waiting rooms, hallways, anywhere where you may come across other patients. And you want to try to schedule major procedures in May or June when rates of respiratory viruses tend to be low. And discuss with your provider if you should be receiving prophylaxis with antivirals or monoclonal antibodies if you need to have a significant procedure performed. And as much as possible, you want to enact public health strategies and mitigation strategies so that you can lower your exposure time and dosage to airborne diseases. From this presentation, I hope you realize there is still a lot of advocacy work which needs to be done. When possible, vaccinate. Advocate for the rapid development and availability of low-cost vaccines. Vaccine testing must be as comprehensive as possible, but not to the point where it reduces the efficacy of boosters due to delays and genetic drift of the virus. In addition, we need to have testing specifically for organ transplant patients. We need to advocate for the development of inactivated viral vaccines to be used in immunosuppressed patients. We need to advocate for universal masking in healthcare settings and early AM time slots reserved for those who are immunocompromised. This will allow safer treatment and lessen your chances of being exposed to pathogens. We need to advocate for appropriate public health strategies to lower your exposure time and dosage to viral pathogens. This includes wearing N95 masks or respirators and avoiding indoor settings that do not have adequate ventilation or safe air. And we need to advocate for the readily availability of prophylaxis so that if you have to go to a high-risk activity or exposed to a viral pathogen, you can obtain treatment. Now, this slide shows the major references used in this presentation. You can download these references in the presentation slide set on HealthWatch USA's homepage, which can be accessed at https://healthwatchusa.org. Thank you very much for inviting me to present at this very important forum and to be able to relay this important information to you. Thank you.
Thanks again, Dr. Kavanagh, for that superb presentation. I have a few questions for you. You have long known, and many of your colleagues obviously have known, that dialysis patients and kidney transplant patients go through the phenomena that we call immunocompromised and immunosuppressed, and we live with it. And over the past 4 or 5 years, there seems to be an uptake in public understanding and medical professional understanding of those particular vulnerabilities. And I'm curious, based on what you've seen through HealthWatch and also through what you've read, is that a result of increased viral threats, or is it an indication of greater awareness and education that's happening, or is it both?
Well, I think definitely it's both. You need to realize that multiple infections are on the rise. This includes measles, tuberculosis, whooping cough, RSV, streptococcal, seasonal flu, you can go on and on. The spike in seasonal flu last year was huge. But at the same time, there seems to be developing a disregard for public health measures in our society. And it's been striking. I mean, kidney patients used to be safe from a lot of infections, such as measles and chickenpox, because of herd immunity. People looked out for one another. But this is eroding. And unfortunately, the vaccine for MMR, which is measles, and chickenpox vaccine are live viral vaccines, and they can rarely be given to patients with transplants. And so we're really in a, kind of in a very unsafe situation right now. And in addition, both COVID and measles will erode one's immune system. So to make matters worse, once you get infected, you have decreased susceptibility to fight infections. Even patients with mild disease with COVID are at risks of having immune susceptibility to infections. And so we need to have really a lot more support from the community. And we also need more support from the federal government. The FDA's approval of for example, of the Novavax COVID vaccine pretty much just emphasizes individual health. It's just approved for patients who are over the age of 65 and if you have one comorbidity. It's not approved for the general population. And so this completely ignores the preventive benefit of vaccines against long COVID, but also the need to protect others. And that includes high-risk coworkers, family members, and friends. And you also have problems with the bird flu. I mean, this is getting more and more of a problem. It is affecting our food supply, food prices, egg prices, and I think it will just be a matter of time before this virus jumps from birds or cows to humans. And when that happens, it's going to create another unacceptable risk for renal transplant patients. So, yes, I think it's going to be both factors. We've got a lot going on in infectious diseases, which are trending in the wrong direction, but we also have much more awareness among people who are susceptible to these diseases. And so I think that at some point, we're going to see more movement into prevention and more movement into protecting those who are immunosuppressed and compromised. At least that's what I'm hoping for.
Well, thank you. On the live vaccine issue, I know as a transplant patient, I was warned very intensely once I got that to always make certain that at the point that I'm doing my regular medical checks in preparations for the coming year, to always make it very clear that I can't do some of the vaccines that you mentioned because of their live nature and because I'm immunosuppressed. Are you confident with new technologies, more precision medicine, and the advancements in technology that we may actually see more solutions that are better tailored to those who are the most at risk?
It seems like the smaller the group which will benefit from the vaccine, the harder it is to get the product developed. And so, for example, we need to get deactivated viral vaccines for measles and chickenpox. And these need to be developed. And that's going to incur costs, but I think that should be related to the cost savings and avoided treatments that would take place if these vaccines were available, because you'll have a lot less sickness in patients that are immunocompromised and immunosuppressed. And in addition, I think we need to really make it clear that the massive cuts we're seeing in federal support for vaccine development is really not a good idea. For example, there's a grant for a COVID-19 mucosal vaccine, which really holds promise in preventing the spread of this disease. And that grant was placed on hold, and even a pause in a clinical trial that can adversely affect the vaccine's availability. Can adversely affect the clinical trial's validity and, of course, will affect the vaccine's availability. And we've also seen a lot of NIH funding for COVID-19 research being put on hold. And I think that the AAKP is one of the organizations which I hope will be able to give the voice to people who need this, who need these drugs developed and available. That's a very, very important mission, I think, of the organization.
I appreciate your comments, and especially your distinction on making the human argument versus, for example, the cost argument. Obviously, we don't make too many of those distinctions, but the argument on the taxpayer side of things we think is pretty strong, because when the most vulnerable people, like kidney patients, many of whom are on Medicare, get sick, it inevitably costs society and taxpayers more money. And so, we spend millions and millions of dollars in immediate treatments and billions of dollars in dialysis care and transplant care in the United States. So we see those as public investments by taxpayers in protecting patients who are recipients of dialysis or transplantation. In our view, always makes sense. And we're pretty vigorous in fighting efforts that curtail that, because it just doesn't make sense to people, families, and it doesn't make sense to taxpayers. The other thing we've been very strong on is that kidney disease is not simply a healthcare issue, it's a workforce issue. And so as we're trying to encourage people to get off of disability and to further engage in the workforce in part-time or full-time meaningful jobs, it's very important that they have the means to stay safe and keep earning an income and paying taxes. So I appreciate your comments in that regard. Let me ask you this. Based on the presentation that you gave and some of the questions in the back and forth that we've had here, what are the key top line points that you would want people to walk away from this session if they were patients, a message for researchers, and a message for industry? Pretty interested in your view because you've been in the arena for a long time.
Yeah. Well, the message for kidney patients is don't rely on others to keep you safe. You need to be proactive and you need to take action to best protect yourselves. And I feel that vaccines give important protection, but not to the level which you require, and so that additional protections are going to be necessary. And this would include using N95 masks, respirators, and use CO2 monitors to monitor indoor air quality. I would also really encourage you to work with your employer or provider to really improve the safety of indoor air and venues that you have to enter. Certainly, if the venue wasn't safe, I would avoid going into it. And if you have to go to a restaurant, consider eating outside or having an order takeout. And if you have to do shopping, I would shop as much as you can online, because retail establishments often do not have safe air. Some do, some don't. And of course, that's one of the reasons why a CO2 monitor is helpful. For researchers, I think we need to remember that not all solid organ transplants are the same. There's a big difference between a kidney transplant, a heart transplant, and a lung transplant as far as the risks of infection and the ability of that patient to fight off diseases. And there's an urgent need for development of deactivated viral vaccines, as we've discussed. This includes those for measles, MMR, chickenpox. There's a variety of them that we need to have new vaccines developed, because we are rapidly losing herd immunity in this, in many of our communities. And renal transplant patients, they're really being exposed to increased risks. We need to have more research in the timing of vaccinations in relationship to immunosuppression protocols. And in general, we need more information on vaccine efficacy in kidney dialysis and transplant patients. It's very hard to find vaccine efficacy studies on specific patients that have had specific transplants. And we need the rapid and ready availability of immune globulin and the development of antiviral agents. So I think all those are very important for researchers to consider. For industry, is, I think one of the areas we can have the biggest impact. Now, certainly if you look at the medical industry, we need increase in vaccine development and distribution infrastructure, and the same is true for antiviral medications. But all companies, industries, and retail establishments need to have safe indoor air, and this includes monitoring of CO2 levels and increasing ventilation. When the latter is not possible, HEPA filtration or germicidal UVC lighting should be used. And for medical facilities, they need even more stringent requirements. They could be doing early morning appointment times for immunosuppressed patients. And I think mandatory masking at healthcare facilities is something which needs to be done because, believe me, healthcare facilities are the one area where immunosuppressed individuals and patients commonly meet those with active infections. And so I think that we need to advocate for safer medical facilities and overall cleaner air in our retail establishments.
Thank you very much, Dr. Kavanagh. And I know that over the years, you and AAKP have had a mutual interest in pushing back and demanding greater accountability and transparency with the FDA as they were developing the approvals, the emergency use for COVID vaccines. None of those approvals included dialysis patients or transplant patients. We were extremely concerned about that and quite candid in our comments. And over the years, you've been a great voice in front of the CDC's Infection Control Practices Committee. And we overlapped on many different issues there, reminding the CDC of what their true mission was for citizens in protecting them. In many cases, sometimes when they were more involved in mission creep or mission rollback. So as always, appreciate your candor and very much appreciate your time in joining us. I know that you just went through an episode in Kentucky where you were impacted and your neighbors were impacted by tornadoes. The fact that you carved out time to be with patients here in the U.S. and across the world, we really respect that and really respect your dedication to keeping people safe over your career. So thank you very much.
Well, thank you for giving me the opportunity to talk before your very important group.
You bet, Dr. Kavanagh. Stay safe. We'll talk soon.
Thank you, sir.